recording has started. Thank you for agreeing to that. It allows us to capture your comments and the input that we received today. Again, for the live interpretation, we've covered that. If you need live captioning, you can select that CC button on the bottom of the screen. Alrighty, let's move to the next slide. For today, this is our plan for the next couple of hours. We may not need the full 2 hours, but it's nice to have that time blocked so we can have a good conversation. Again, during this introduction section, we will cover the Oregon Health Authority vision and health equity fact sheet and review the RAC participation fact sheet, as well as confirming the members that have registered to be a RAC member. So I'm going to ask Nita to call off the names of the people who signed in to be a RAC member. So we can make sure that we capture if they're here today. Thank you.
Can people hear me? I need to move closer to the mic.
Speak up.
Yes, we can hear you.
Thank you. Going to start reading the attendance here. I'm just going to borrow your pen, Diane. First, we please correct me if I mispronounce your name. We have Stephen Shearer with Care Oregon. Please
Good morning.
Oh, perfect. Thank you. And we have next Holly Jo Hodges with Moda Health.
Yes, I'm the CMO for EOCCO.
Thank you. We have Laura McCain with All Care Health.
Yes, I'm here.
Thank you. So we have Marty Hardy with Oregon Primary Care Association.
Here.
Thank you. Morgan Rains with Outside In. Okay, I will just say it one more time. Morgan Rains with Outside In. Are you here today? All right, I'll move on. We have Deanne Carr with YCCO. All right, Deanne Carr with Yamhill CCO. Are you here today? All right, next we have Laura Pommier with True Course Counseling. Right, Laura, are you here today? Next, we have Miriam Herman with Trillium Community Health Plan. All right, Miriam, are you here with us today? Okay, that is who we have as registered attendees, but we will also check the chat section if somebody joined in and isn't on this list.
Thank you. Thank you, Nina. So again, I know there are quite a few other folks here in attendance today. registered to listen in and observe the meeting, so appreciate those participants as well. We will, after we review the participant fact sheet, we'll dig into the actual rules. I mentioned that we will be looking at 3 Oregon administrative rules in chapter 410. We have 1 in division 120, which are general rules that apply to medical assistance programs, and 2 rules in division 141 that are those division 141 rules that Darren will facilitate the conversation relate to our coordinated care organizations, or CCOs, that are part of the Oregon medical assistance programs. And you'll see I estimated time frames for those different rule sets. Again, we may not need that much time, but we'll just push through. And then we will talk about the statement of need, the fiscal impact, and the racial equity impact considerations for these rules. And then we'll wrap up with some next steps. Okay. Let's go ahead to the next slide. Edgar, when you have a moment. Thank you. This slide, I want to spend a few minutes here to simply ground us in this work as we come together. It's important that we think about the impacts of what we do in terms of rule development and program development, that we consider how these efforts impact the health equity of the people who live, work, and play in Oregon, and how that ties into the Oregon Health Authority's mission and vision. And simply, our mission and vision is that we will have a healthy Oregon where people and communities achieve optimum physical, mental, and social well-being. So really thinking about the whole person, your physical health, your mental health, and your social health. I'm going to just make a pause here because today is, October 17th, and it's 10:18 according to my computer. And if you are aware that there is a effort once a year to do sort of earthquake preparedness on 10/17 at 10:17 in the morning. So let me pivot, and if Edgar can go to slide 7 quickly, sorry. Okay, so the great shakeout. If you're in a place where you're getting some kind of alert about that, just a reminder of ways you can protect yourself during earthquakes. We won't do that here as part of this meeting, but just wanted to provide this information for you if you're mobile, if you're using an assistive device like a cane, a walker, or a wheelchair, ways that you can stay safe in the event of an earthquake. Okay, so that's your public service announcement for the grade shakeout. We'll go back to slide 4. Thank you. Just want to then move on again, thinking about health equity and how Oregon administrative rules and programs can help influence and improve health equity. And our definition here at our agency is that Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. So that's a lot of information, but again, my goal for sharing this as part of rulemaking is to help ground us as we think about these rules and how they can affect both health equity and really making sure that everyone has the full potential to be well, physically, mentally, and socially. You know, the Oregon Health Authority, we recognize we haven't always done a great job with really elevating the voices of the people and communities that are impacted by rulemaking. And so our goal here is to really hear and lift up the voices of everyone who is part of this rulemaking. So again, I appreciate your time commitment for today's meeting and input and as part of this rulemaking. Okay, next slide. Okay, now that we've covered all of that sort of level setting, just take a moment to do what you need to settle in and focus on these next parts of the actual real work that we're here today to do, whether that's if you need to take a deep breath, move your body, shake it out, as to get focused. All right. Thank you. All right, let's go to the next slide. And please, again, feel free to use the chat as you have comments, raise your hand, or if our audio is not good, please let us know. So, thank you. I sent out these materials to everyone who registered via email. So you have these, but we'll walk through them together today. Starting with the Rules Advisory Committee participant fact sheet. So I'll have Edgar pull up the English version of that. Thank you. Maybe, can you make it a little bigger? Perfect, thank you. Right, so, okay. I won't read through this, document since, it was sent out to the RAC members, but just, want to review, some key points about the Rules Advisory Committee and what our role is here today. These meetings are designed to be, an opportunity to get public and interested parties involved to provide input. The RAC members' role is advisory. We don't have to come to consensus. Again, we're looking at both new rules in these meetings, or amendments or repealing of existing rules. Today, we'll be talking about amendments and a repealing of one rule. And then again, we'll look at the other impact statements. Scrolling down to what's expected as a RAC member, I will facilitate the conversation for the Division 120 rule. And then Darren will cover the information about the Division 141 rules. We'll talk about the substantial changes to the rules, and we'll have some conversation there. We do have subject matter experts, perhaps other Oregon Health Authority staff who are here that may be called upon to explain rule changes and answer questions. And we also have Oregon Health Authority staff attending today. And they are not RAC members per se, so they won't be offering input to the comments during this RAC meeting. And then thank you, welcome, Deanne Carr. Going on to the next page. For RAC members, you may not think of everything to offer today, but you're welcome to send that information to me. My email is there, and please send it by 5 p.m. Next Friday, a week from Friday, so October 25th. And then a quick overview of the next steps, and we'll cover that at the end of the meeting as well. Okay, so let's go back to the slide. Actually, we can just go next to the Division 120 rule. Thank you. Maybe not make that consolidated. Perfect. That's fun. Okay. So again, this rule, simply called telehealth, is in chapter 410, Division 120, and it's rule 1990. So these are amendments, proposed amendments to this rule. And you'll see that some words are have a line striking them out. That means that we're proposing deleting those words. And if it's underlined, and here it's showing in red for those changes, if it's underlined, those are words we're inserting. Are proposing to insert in these amendments. The key thing is there are some changes that we'll have throughout these rules that I'll talk about initially, but you'll just see those changes carried throughout. And one of those first changes is that the Oregon Health Authority created two divisions, one called Medicaid division and one called Behavioral Health division. So this change is to remove the reference to the health system division name and to insert the Medicaid. So again, you'll see that in several places throughout the rules. And you'll also see that we're striking the word telemedicine simply to streamline the language, make it a little easier, and just refer to telehealth services. When we have definitions in another general definition rule, we are removing the duplication of those definitions in these rules. So you'll see reference to that. So most of those are, again, just sort of, I guess, simplifying the language, doing some cleanup, grammatical changes, really not substantive in terms of intent or content of the rule. We are changing wherever it said shall, we've changed that to must throughout these rules as well. So I'm going to go through these rules and invite comments, and I'll do them in sort of some chunks of sections. So looking first of all at sections 1 through 3, which really is right here on this first page. You've got one, or actually goes through about to the middle of page 2. This first section is really all about definitions. So it's a lot of that to sort of clean up. So as you look at sections 1 through 3, I'll pause and invite comments from RAC members. Again, if you want to come off mute, if you're able or comfortable turning on your camera, that's awesome. Or you can put your comment in the chat, that works. And if you're speaking, if you're coming off mute, if you could again state your name and the organization that you're affiliated with, that will help people who perhaps are listening just via audio today. So again, sections 1 through 3, any comments from RAC members? Okay, I'm not seeing any hands or comments. So I'm gonna go ahead and move on. About the middle section of page 2 is the start of sections 4 and 5. So what you see there are some, again, some words that are stricken out and some words inserted. What we're aiming to do with these rule amendments is to cover what's expected for both CCOs, coordinated care organizations, and fee-for-service providers. So there are things that apply to both of those delivery systems, models, and then things that are specific to CCOs. So you'll see where we've separated them, we've called that out. And so you can see the changes there. Again, pulling things that were have currently in the 141 3566 rule, and folding that into this general rule.
We have a hand up.
Okay.
Deanna. Oh, Deanne.
All right, Deanne, go ahead. If you
Yeah, I apologize. When you were first said the first three, I thought we were going item by item. So I thought it was just those first three on the page, which is why I didn't speak up, because I do have a couple comments for those, apparently that the definition section.
okay, go ahead.
Okay, so right on the page there, 4D. I would like to recommend that we add a sentence to it. That says that basically it's memorializing that synchronous shall be considered to meet face-to-face requirements. That shows up in other OERs, but it's never quite landed in the telehealth OERs, and I think it was just, as they got put together, it just didn't end up in there. So I will, here, let me paste in chat. Just keeping the sentence very simple and to the point was my thought. And then the other item was under 5B. It's all new language there. I'm concerned about the second sentence that says that basically anytime the in-person, the telehealth provider is referring to another provider, that they have to inform the CCO. It's not always going to be necessary, and I think that would create administrative burden for the provider, as well as maybe confusion for the member. Now, that said, I'm not suggesting deleting it in its entirety. My suggestion would be to convert the sentence to as needed. CCOs will include an applicable provider contract language that providers unable to offer in-person service shall inform. It basically, well, actually, I'll move the as needed. So I had that in the wrong spot. I'll put it in the chat, what I was suggesting, but in general, I thought I'd throw it out there to see if others had similar thoughts. But if they're just having to tell the CCO just cause, and there's not really any issue there, I don't know that gets us, that's additive.
Okay. Thank you, Deanne.
Laura,
Appreciate that.
Laura has a hand up.
Okay, and
Hi there. I just wanted to clarify what an SPN, just so I make sure I understand. When you were talking about the synchronous SPN, are you requesting that the actual language be in there face to face?
Yes, I think that pops up, and so I think it's very helpful to have the
Yes.
sentence that I copied and pasted there. That way it's just overt.
Yep.
Right there. Boom.
Perfect. Nope, I completely agree with you. Thank you. I just wanted to make sure I understood.
okay, thank you both. Okay. Other RAC members who have comments about sections 4 and 5. Okay. You will notice that, there's a significant sort of renumbering and really reducing overall the total number of sections, so, that's why you'll see like, say, sections, what's called 6, used to be section 14. So sections, 6, 7, and 8, which again, those start on page 2 of that rule and go through page 4. So it's 6, 7, and 8. Really no substantive changes in those sections, just that cleanup in terms of removing telemedicine, changing shall to must, referencing other definitions or other Oregon administrative rules that are listed in the general Division 120 definition rule. So I'll pause and see again if there are any comments about sections 6, 7, and 8. Takes us pretty much through the end of page 4. I'll check the chat.
Deanne has her hand up.
Okay, thank you.
Sorry, Deanne, YCCO. Section 8, I don't have an issue with it, just more of a clarifying question. Providers who offer telehealth delivery of service must meet the following requirements. Hold an unencumbered organ license. So is that applicable to telehealth only individuals, or is that also, let's pretend I'm a private practitioner in Oregon, and I do both in-person and telehealth. I just wanted to clarify. I'm assuming that it's an all of the above, but just for my own clarity.
Sure, thank you for the question. Yes, providers who offer any health service, whether it's delivered via telemedicine, telehealth modality, or in person, have to be licensed in Oregon.
Thank you.
Applies to both. Other comments about sections 6 through 8? Okay. Moving on to section 9, which is at the top of the next page, 5. This section describes the reimbursements requirements or standards, again, folding in the information that currently is in the CCO rules and incorporating that language into this one general rule to really, in an effort to consolidate and standardize and assure that we have the same expectations and commitments for both CCOs and fee-for-service members, so that they all have equal access to services delivered via telehealth. So pause and invite any comments about section 9, which is really all of page 5. Okay, Deanne.
Deanne again, YCCO. If you scroll back up, the reimbursement needing to, for the, there we go, big B. Shall reimburse interpretation using the same reimbursement rate as if it was provided in person. The only speed bump I see there, I mean, I is in case the reimbursement were to include travel costs. And in which case then in person would be more costly. And so I do wonder about some language that, you know, the same service reimbursement rate excluding travel costs as if were provided in person would be my suggestion, just because I know that that comes into play. Let's face it, it's not cheap to go to the gas pump.
Appreciate that comment. Yeah. Other comments about section 9? Okay. Moving on to the final section of this rule, section 10 on page 6 of this packet. This again, not substantive changes to this rule. We did remove the statement about defining an established client or member as a patient or client who had received an in-person encounter every 3 years. Again, incorporating the requirement for this to apply for both fee-for-service and CCO services in the event of a declared emergency. And that network adequacy requirements still apply for CCOs. Again, that was pulled over from the Division 141-3566 rule.
Deanne here, YCCO. I'm feeling uncomfortable with little c. I understand the intention behind it, but if we're talking things are bad enough that we've got a declared emergency and the authority has flexibility, but yet then we turn around and say, well, it's, you know, yes, there was a hurricane, tsunami, earthquake, volcano event, you know, but good luck, you still need to have network adequacy. I do think that maybe we need to look at that language that I would actually suggest shifting it that should the authority exercise this option or this exercise option in section 10, the authority may also choose to choose flexibility in application of CCO obligations for network adequacy and take out remain in full effect. I think we want to actually give the authority the ability to say, you know, this is bad enough. We expect you to maximize network adequacy, but we also know that, you know, the roof just came off, or, you know, we're in some other weird pandemic thing. Because if it's that bad, then I don't think C flies as written.
Okay, I appreciate that. We'll take that back and Holly, thank you, added a comment. So we'll see about that. I don't know if Darren wants to provide any context. Darren Kaufman is the sort of subject matter expert on the CCO application, so.
Hi, this is Darren Kaufman, Managed Care Analyst with the CCO Operations Unit in OHA, he, him pronouns. Yeah, thanks, Deanne. I was just trying to quickly scroll through because it does reference the network adequacy rule there, and I was just trying to quickly scroll through that to see if by chance that had any other kind of flexibility language in terms of those situations. Haven't scrolled through it completely in the few seconds that I've had here, but we'll certainly look into that and certainly appreciate the comment.
Great, thank you, Darren.
Thank you. And I threw some language in the chat there. Hopefully that's helpful.
Great, thanks.
Thank you. Okay, well, that's the end of the Division 120 rule. So I think we'll pivot and I will turn it over to Darren to walk through the two Division 141 rules. So go ahead, Darren.
All right, so Edgar, if you could just bring up the those sets of rules, there you go. And so, you know, I've got this, have Edgar putting this on the screen, but as you'll see, it's just a whole bunch of deleted language because the plan is to repeal this 410, 141, 3566 rule. So as mentioned earlier, there were actually, I don't know if you noticed it, but there were kind of two main pieces of language that turns out are unique to this current CCO telehealth rule that we're proposing to add to the 410, 120, 1990 rule so that all the telehealth rules are in one place. The other 90% of the current telehealth rule basically duplicates language in the Division 120 rule. And actually the Division 120 rule was modified more recently, and so it's in a little bit better shape. So we're kind of proposing to keep the language that's in the 120 rule, then carry over all of that kind of out of date duplicative language in the 141 rule. So basically moving over two sections they were on, and I think Deanne might have commented on both of these, so we appreciate that, and we'll take a look at that. But it was the provider notifications to CCOs when they refer for in-person services, and then there was just one more unique one on CCOs reimbursing certified and qualified healthcare interpreters at the same rate for in-person services. So what we're proposing is by doing that, we then can repeal this 410, 141, 3566 rule. I'll actually note that we found that there was one other piece of unique language in the Division 141 rule that was actually giving conflicting instructions on how to indicate the place of service code for telehealth services. So we are choosing not to carry over that particular unique language and getting rid of that contradiction. And then Edgar, if you can scroll down a bit to the 410, 141, 3820 rule. Ways, yeah, there we go. So then in repealing that 3566 rule, we'll still just need to refer to the Division 120 telehealth rule somewhere in Division 141 so that CCOs know what is being required of them when providing telehealth services. And the best spot that we found to do that was the covered services rule. And if you can scroll down, Edgar, we are proposing to add a sentence for new number 7. So it's going to be a little ways down. There we go. And so just quite straightforward, telehealth services must be provided in compliance with this OAR 410-120-1990 rule. So that is the proposal, so that, you know, people just have one place to go to when they're looking for these telehealth rules, and would love to hear any additional feedback on this part of the proposal.
Deanne here, I appreciate y'all kind of moving the telehealth rules into just one location. I think it streamlines things, so that's appreciated.
Great to hear that, because we thought the same, and you know, we'll be looking at if there's other rules. That this is kind of the first time that we've done something like this, and so as I look through other CCO rules, if I see other opportunities to do something similar, so things that aren't specific to the CCOs, then we may come back with you and do similar proposals in the future. So thanks for that feedback.
Yeah, Darren, this is Holly Joe. I agree. Thank you for solidifying and simplifying.
Great. Thanks, Holly Joe. Nice to hear from you again.
You too. Miss you.
All right. Any other comments on that? All right. With that, Diane, I'll pass it back to you.
Okay. Terrific. Well, we did that, that part. So let's go back to the slides. And we'll go to slide 8. Okay. We want to take the next few minutes, or however long we need, to have some conversation around the questions about how these rules may impact racial equity, health equity, and any sort of fiscal or financial impacts. So again, thinking back to the Oregon Health Authority vision for a healthy Oregon, where everyone has the full potential, the ability to achieve full health potential, and that there aren't populations that are disproportionately impacted. So I guess the first question I would pose to the group, again, invite comments either verbally or in the chat. Do these rules, or how do these rules impact racial equity?
Deanne here, YCCO. As I'm thinking about it, I'm sort of maybe rolling both the first two or all of the questions kind of thing, is that I think that with telehealth, it's really broadened access for individuals who maybe don't live close to sort of population centers. So as we look at urban sprawl of, folks that maybe can't afford more expensive housing, are having to move to outlying areas, which makes access more difficult. And so as we look at sort of populations living in poverty, which of course our OHP members are part of that we begin to open that up. And while sometimes there's, obviously Wi-Fi issues, I think that we are seeing more and more that the majority of folks do have a cell phone and that ability to actually attend a session, whether or not they have access to Wi-Fi. And so I think that that's a critical piece, and the more we can do to support telehealth and its access, the better. And I do think that for individuals who are monolingual or have a non-English preferred language, that ability to, use telehealth and have the interpreters just sort of join that meeting, I think it increases access and bandwidth for interpreters, because they're not having to drive from location A and then they're in their car for a half hour, or bad Portland traffic, 2 hours, to get to the next location. So I think we increase the efficiency of the use of interpreters' time. And so I think that that's another critical piece as well. A fiscal, probably a little more indirect. My comment would be more around just the systemic need to continue to improve Wi-Fi in outlying and rural and frontier communities, to make sure that people have access to good synchronous telehealth, versus having to go off video because there's not enough Wi-Fi oomph.
Yeah. Thank you, Deanna. Other comments about impacts to specific populations, or any fiscal impacts? And those impacts, in terms of financial, could be for members, for partners, for advocates, for providers.
Yeah, and again, I think with that suggestion I made around whether a provider needs to always inform the CCO when they're transitioning a member versus as needed, I do think that there's an impact on provider time, and provider time does have a fiscal implication. I mean, it's a smaller concept, but I do think that it's important to be mindful of that impact on our provider network.
Yes, appreciate that. Okay, again, if RAC members have things that they think about after we end today's meeting, I know how that is. Sometimes you get out of a meeting and think, oh, I forgot to raise this point. So we will have, you'll have the opportunity to send those to me via email by the 25th. Before, I think because it's just a little after 11 and we booked this time till noon. I do want to now give a few minutes to open it up for if there are comments from people here today who registered just to listen and observe. If you want to post a question in the chat or come off mute, tell us who you are and what your comment is. We'll welcome that now.
I do have a question. I'm spearhead with Advanced Health CCO, and I appreciate this. We recently have been working on credentialing some telehealth only providers that don't have any office brick and mortar spaces besides their local residents. And I'm curious as to how OHA would like us to manage the provider directory and in those situations where there isn't a physical address that the provider is comfortable using. In those situations, is it appropriate just to leave that as NA?
I'm not sure I know the answer to that question. I guess a follow-up question is, are you talking about, as you contract? Or is it for, fee for service, open card, provider enrollment?
Diane, can you repeat yourself? Actually, there was noise, and so it was hard to hear you.
Oh.
If there's to go off mute, that or go on to mute, that'd be great.
Okay. Yeah, I think my question, let's see. Okay, so Lucille, if I understand your question or your comment is about the address to be used in the provider directory for a telehealth only provider. Seemed like I saw someone offer a comment, telehealth only can be listed as the address. That's a suggestion to OHA. I'm not sure what the requirements are for the CCO provider directory information. So we'll have to take that back and look into that. I know that in terms of for Oregon Health Authority, a telehealth only provider can enroll and use a business address, even though they might be providing telehealth via their home address location. So. Okay. Anyone else from the non-RAC member community here today that have comments about today's rules that we discussed?
Diane, this is Darren. I just wanted to let Lucille know that I'm dropping my email address in the chat, and so she could contact me about that question, and I can get back to her with an answer for the CCO provider directory.
Perfect. Thank you, Darren. Yeah, we've got that in the chat.
Hi, this is Lucille. My question wasn't around the directory. My question was around the ADA accessibility. I believe Kara asked the question about the directory.
Okay.
But to add to that, we have had the same struggles as Kara has mentioned. And in addition to that, there was discussion about network adequacy. There is additional thought that needs to be given around telehealth only, especially when there is no address to essentially triangulate whether or not a provider or a network is within time and distance standards. If there's no address, usually that that measurement is done through geolocation of member address to provider address. I believe that, you know, that these expansions to the telehealth requirements are great, but I believe that the related requirements as far as provider directory and network adequacy, time and distance haven't caught up to the updates that are being made, for example, in this conversation. So we, IHN CCO, and I'm sure other CCOs would be, very excited to hear what is coming to address those changes as well.
Yeah, thank you for clarifying the various questions. Yeah, it was getting out the audio, at least on our side, was a little bit rough. So appreciate that question, the comment, and we'll take that back. I also I wanted to invite, there's a subject matter expert here from our provider enrollment team, Tiffany, who might be able to provide some more context around that provider enrollment and address question. So go ahead, Tiffany.
Sorry, I had to unmute myself really quick. Can you hear me okay?
Yes.
Okay. I just wanted to touch bases real quick on the address, at least for the fee for service side. I don't know how it's done on the CCO side for the enrollments, but for the fee for service side, we do require the address where the provider is physically located. If that is their home address, that is what they have to supply to us. We have had in the past, and we still have, some out-of-state organizations who will use a like a PO box mail service location in Oregon to try to enroll. By doing that, they're kind of going around some other requirements as far as, PA or modifiers on claims, variety of different things to try to get enrolled, essentially. So we do require the physical address where the provider is located.
Great. Thank you for that correction and clarification, Tiffany. Appreciate that. Okay. Well, let's go ahead. I heard
Yes,
somebody-
sorry. Do we have time for one more question?
Yes,
Okay.
go ahead.
All right, so this is Yvonne from Oregon Community Programs in Lane County. And my question goes back to Rule 410-120-1990, Section 7A, concerning the readiness assessment, the telehealth readiness assessments. And our question is, does OHA have a readiness assessment form, or do guidelines or OARs exist for what the readiness assessment should include? What are those requirements? And then, and how might those requirements result out or be measured during an audit? I think some providers sort of feel lost without, what are the expectations? And that would help.
Yeah.
To have the proper assessment.
Thank you, Yvonne, for that question. We do not have any template or readiness assessment tool. I don't believe that we have that in rule anywhere or any tools, but we'll take that back as something. I know we've talked a little bit about that internally, but haven't really come to any conclusion about what to do with that. Instead, kind of deferring to organizations to develop that rather than dictate what. But I appreciate the input and understand the need for some.
Yeah, and just maybe less requirement and more like guidance even, right? So that there is some guidance. We want to make sure that we have enough that is proper, but then when we consider audits, we don't want to be on some other page, right? Where maybe that doesn't meet whatever OHA may have in mind, when it comes across the audit. So it's just to be able to have some consistency, for that as well. Also in protecting the clients, making sure they are ready, and able, of course, that's important as well. So,
Absolutely. Yes.
thank you.
Yeah. All right. Appreciate that. Thank you, Yvonne. Anyone else? last call. Yeah, appreciate that, Holly. Okay. Got some guidance with some flexibility, appreciate that. All right, let's go to the next to final slide. So again, just reviewing the next steps in this rulemaking process. Again, RAC members, welcome to submit written additional comments. Send those to me at my email address there, diane.s.querying@oha.oregon.gov. Our target, our goal is that we would file with the Secretary of State's office for these notice of proposed rulemaking. So again, taking what we get from today's meeting and any additional emailed comments from RAC members and having that folded into what we consider for proposing by the end of October. If we meet that goal date, then we will, it will be published in the Oregon Bulletin November 1st, which would open up a public comment period. So during that public comment period is when anyone can be submitting public comments to the proposed rule language. There is typically a public hearing. The date is to be determined. The public comment period is 21 days, so it would close on the 21st. And then again, based upon the comments that we receive, we will make any additional changes to the rules that would be part of the permanent rules that would be filed with the Secretary of State's office. And a goal of having the rules take effect first quarter of 2025. May not be the exact first of the calendar year, but sometime in that first quarter. And again, all these stub dates are estimates, which may change depending on how many public comments we receive and any other internal review and approval process we have on our end. Okay. And lastly, final slide is again, just want to thank you for giving us some of your time today and your comments in chat and verbally. We greatly appreciate your engagement and support as we move these telehealth rules forward to increase access and assure equitable coverage for people who receive Oregon Health Plan. So thank you, and we'll close out the meeting and hope we don't have any earthquakes in the near future, but wish you a great rest of your day. Close the meeting.